Usually when we talk about a medical diagnosis, there is this underlying expectation of precision. It feels like, I don't know, almost like engineering.
Right, yeah, like it's a math problem.
Exactly. You break your arm, the x-ray shows this jagged white line, the doctor points to it, and boom, the problem is identified. It's clean, it's visible, and it's completely isolated to your physical body.
And that binary view of medicine is, I mean, it's deeply comforting, right? We naturally want diseases to be these contained, categorized problems that we can just solve with a pill or a scalpel.
Yeah. But if you step outside that pristine clinical environment and you go into the world of global health and infectious diseases spreading through deeply impoverished communities, that metaphorical x-ray machine just kind of shatters.
Oh, absolutely. It shatters completely.
You aren't just looking at a straightforward biological malfunction anymore. We're looking at a diagnostic landscape that is incredibly murky.
Because you're entering this realm where biology collides directly with sociology. The pathogen might be, a virus or bacteria, but the delivery mechanism is the entire lived environment of the patient. The housing, the water supply, the political history of their country.
Which brings us perfectly to the mission of our deep dive today. Welcome to the conversation, everybody, and especially to you, the learner. We are so glad you're joining us for this one.
Yeah, it's a fascinating topic today.
It really is. Today, we are opening up a massive stack of source material centered around a comprehensive biographical profile of an American medical anthropologist and physician, a figure who was famously described as the man who would cure the world, Dr. Paul Farmer.
A truly towering figure. His approach fundamentally dismantled that pristine, isolated view of medicine we were just talking about.
Yeah, and our goal for this deep dive is to explore how a man who spent his childhood literally living in a converted school bus went on to completely upend global healthcare. We're going to dig into the actual mechanics of how he pioneered this revolutionary model, a model that treats poverty, history, and social inequality not just as, unfortunate background noise, but as actual diagnosable medical emergencies.
To really comprehend how he pulled that off, you have to look at the dual identity he carried throughout his life. He wasn't simply a Harvard-trained physician. He simultaneously held a PhD in medical anthropology.
I want to pause on that for a second because medical anthropologist can sound like a very dry academic title. What does that actually look like in practice compared to just a standard doctor?
Well, think of it this way. A standard clinical doctor looks at a patient with tuberculosis and asks, okay, what antibiotic will kill this mycobacterium?
Right, standard procedure.
Exactly. But a medical anthropologist looks at the exact same patient and asks, why is this person living in a crowded, unventilated room where tuberculosis can spread? What labor conditions force them there? And why can't they afford the bus fare to the clinic to get the antibiotics?
Wow, okay.
The doctor treats the pathogen. The anthropologist diagnoses the society that allowed the pathogen to thrive in the first place. Farmer fused those two disciplines seamlessly.
It is a remarkable combination of perspectives, and when you look through his biographical profile, you realize this worldview, it wasn't born in some comfortable Harvard library.
Not at all.
It was forged in a highly unconventional, deeply precarious childhood. He was born in Massachusetts in 1959, but his family of 8 eventually relocated to Florida. And they didn't move into a standard suburban neighborhood. They moved into an old school bus that his father had converted into a mobile home.
Which is a living situation that subjected them to the immediate daily realities of resource scarcity.
And it gets even more extreme. They eventually moved out of the bus and onto a houseboat anchored in a primitive bayou in the Gulf of Mexico, a place called Jenkins Creek. Our sources highlight that they didn't have running water.
Wow.
Yeah, they had to haul heavy jugs of drinking water from a nearby town just to survive the week. They bathed in the bayou. They faced relentless financial hardships.
And, when you study figures who reach the absolute pinnacle of elite academia, there is often this assumption of inherited privilege or immense safety nets.
Right, like trust funds and prep schools.
Exactly, but Farmer's early life shatters that assumption. He understood the physical toll of poverty on a visceral level because hauling your own drinking water completely changes your relationship to infrastructure. You don't take a clean tap for granted when you spent your childhood carrying water just to avoid dehydration.
And that proximity to hard labor, it extended right into his teenage years. To help make ends meet, his family worked during the summers picking citrus fruit. And the people working alongside them in those Florida groves were largely Haitian migrant workers. This was his very first exposure to the Haitian community.
A community that would define the rest of his life, really.
Yeah.
The seeds of his life's work are planted right there in the citrus groves. He's witnessing the grueling physical labor, the vulnerability of migrant populations, the immense disparities in wealth and health. And he carries those observations with him to Duke University.
Where he excels, by the way. He eventually graduates summa cum laude, but while he's navigating this pristine campus at Duke, he's still drawn to the margins. He meets a woman named Sister Juliana DeWolf, and she was working with the United Farm Workers, advocating for the laborers who were harvesting tobacco in brutal conditions near the university.
And through that connection, Farmer isn't just observing the workers from a distance. He is actively befriending them. He's sitting with the Haitian laborers, listening to their oral histories, and systematically teaching himself the Creole language. He is just absorbing their lived reality.
And during this time, he's also reading deeply, and he discovers two massive intellectual influences. The first is a 19th century German physician named Rudolf Virchow.
Oh, Virchow is a huge figure.
Yeah, he's often credited as a pioneer of public health medicine because he was one of the first scientists to argue that an epidemic like the typhus outbreaks he studied wasn't just a biological event, it was a social defect. He linked disease directly to poor living conditions and lack of political power.
Virchow provided the scientific foundation. But the second major influence provided the moral engine, and it came from the world of theology. Specifically, a Catholic movement that emerged in Latin America called Liberation Theology.
Right.
This was a movement actively defying authoritarian regimes and staggering inequality.
And according to the profile, the absolute core tenet of liberation theology is a concept called the preferential option for the poor.
Yes.
Okay, let's unpack this. Because this phrase feels like the skeleton key to understanding Paul Farmer's entire operational playbook. Liberation theology dictates that the physical and spiritual well-being of the most marginalized people isn't a secondary concern. It's not a charity project.
No, it's central.
It is the absolute, non-negotiable priority of society. So he takes this theological mandate and forcefully injects it into clinical medicine. It's like he was building a dual-engine vehicle at Harvard, getting his MD and his PhD in anthropology simultaneously.
What's fascinating here is how radically that preferential option for the poor disrupts standard medical triage. In traditional global health models at the time, the logic was mostly utilitarian.
Meaning what exactly?
Well, you have limited donor dollars,
Yeah.
right? So you treat the easiest, cheapest diseases to maximize your impact. The poorest patients with the most complex diseases were often deemed untreatable because the return on investment was considered too low. Yeah. Farmer looked at that logic and rejected it entirely.
He inverted it.
He argued that the poorest, most structurally oppressed people on Earth didn't just deserve basic, bare minimum care. They deserved the absolute highest standard of medical technology that Harvard-level science could provide because they were the ones suffering the most.
And what separates him from, purely theoretical academics is that he didn't just write a brilliant dissertation on this and call it a day. He actually went to the Caribbean and built the infrastructure to prove it.
Right, he put it into practice.
In 1987, alongside colleagues like Jim Young Kim and Ophelia Dahl, he co-founded Partners in Health, or PIH, and its sister organization Zanmi La Sante, operating in Haiti. They started working out of a hospital in a deeply impoverished area of the Central Plateau called Cange.
This is where that dual-engine vehicle hits the dirt roads. They begin treating patients, but they quickly hit a wall that every doctor in a resource-poor setting hits.
They realize that prescribing medicine is utterly futile if the patient's environment is actively poisoning them.
Exactly. Consider the mechanism of treating an infectious disease. You can give a child a course of antibiotics to cure a severe waterborne parasite. But if that child has to walk back to their village and drink from the exact same contaminated stream that caused the infection machine,
The medicine is pointless.
you are just temporarily interrupting their suffering, not curing it.
So Partners in Health does something unprecedented for a medical charity. They start building not just clinic walls, they build local schools, they construct concrete floors for homes so patients aren't sleeping on mud. They build entire communal sanitation facilities and install clean water systems.
Yeah, they changed the environment.
So what does this all mean? If I'm looking at this from the perspective of a traditional grant foundation or a donor, I might say, hey, I'm giving you money to be a doctor. I want my dollars buying vaccines and stethoscopes. How does a medical organization justify acting like a civil engineering firm? Like, how do you fund paving roads and building water pipes under a healthcare budget?
That is precisely the friction Farmer encountered with the global health establishment. They told him his model was economically unsustainable.
I bet they did.
But Farmer's counter-argument relied on actual clinical outcomes. He demonstrated that building a water pipe is a medical intervention. It is preventative medicine at scale. And the data from Cambridge was undeniable. They successfully vaccinated the local children, they completely plummeted the rates of malnutrition, and infant mortality dropped drastically.
The most staggering statistic in the sources is their work during the absolute peak of the HIV crisis. At a time when an HIV diagnosis was essentially a death sentence in rural Haiti, Zanmi Lasante managed to reduce the transmission rate of HIV from infected mothers to their newborn babies down to just 4%.
Which is incredible. And that required a massive coordinated effort of both medicine and anthropology. You have to provide the antiretroviral drugs, yes, but you also have to provide baby formula so the mother doesn't pass the virus through breast milk. And to safely mix formula, you need clean water.
Okay.
And to ensure the mother is taking your meds every single day, you need a support system.
Which leads to perhaps their most famous innovation, the community health worker.
The accompagnateur.
Yeah.
Farmer realized that a centralized hospital model doesn't work if patients are too sick or too poor to walk 10 miles down a mountain. So partners in health train hundreds of local community members to deliver healthcare directly into the homes of the patients.
They completely decentralized it.
Fully. A community health worker's daily routine involved hiking to a patient's house, literally watching them swallow their daily tuberculosis or HIV pill, ensuring they had a hot meal because taking heavy antibiotics on an empty stomach causes severe nausea, and checking on the family's overall welfare. It was highly personalized, relentless care.
It's treating the community as an extension of the hospital ward, which inevitably brings up the issue of scale. Because when you prove this works in a specific valley in Haiti, the global community takes notice. But the criticism is always, sure, it works when you have a hyper-dedicated genius running around one village, but it's too labor-intensive to scale.
The establishment assumed this was just a boutique model of charity.
Until 1999, when the World Health Organization effectively tapped Farmer and his colleague Jim Young Kim to confront multi-drug-resistant tuberculosis, MDR-TB. This is a nightmare scenario, right?
Like awful.
It's a strain of TB that basically laughs at standard antibiotics. And the prevailing policy at the WHO at the time was that treating MDR-TB in impoverished nations was simply too expensive and too complicated. The official stance was essentially a write-off.
It was considered a tragic inevitability. The logic was that a complex daily drug regimen was impossible to manage in places with weak infrastructure, so treating it would just breed more drug resistance.
But Farmer and Kim refused to accept that. Armed with a massive $44.7 million grant from the Bill and Melinda Gates Foundation, they took that labor-intensive partners in health model and weaponized it against MDR-TB globally. They implemented specialized drug therapies in Haiti, but then they expanded to the slums of Peru. And then, incredibly, they adapted the model for the prison systems in Russia.
Yeah, that's an amazing shift.
Like, how does a community health model built for rural Caribbean villages function inside a Russian gulag?
Because the underlying anthropological mechanism remains the exact same. In a Russian prison, the structural barriers are different than in Haiti, but they're just as deadly. The TB was spreading due to severe overcrowding, chronic malnutrition, and interrupted drug supplies. Prisoners would start treatment, get transferred or run out of meds, and the bacteria would mutate.
So Partners in Health didn't just ship boxes of pills.
No, they applied the accompaniment model inside the prison walls. They addressed the nutrition, they established strict, directly observed therapy protocols with the guards and medical staff, and they rebuilt the supply chain. They proved that if you remove the structural barriers to care whether that barrier is a mud floor in Haiti or a concrete cell in Russia, you can cure the patient. They achieved some of the highest cure rates for MDR-TB in the world, proving it could be done cost-effectively in poor countries.
It completely shattered the reigning consensus of global health economics, and it elevated Farmer from a brilliant doctor to a global visionary. But what I find so compelling is that his vision wasn't just spatial, looking across the globe, it was chronological. He was deeply invested in diagnosing history.
That's a great way to put it.
I'm looking at our sources, and there's a heavy emphasis on his literary contributions, specifically a book he published in 2020 called Fevers, Feuds, and Diamonds: Ebola and the Ravages of History. How does a tuberculosis specialist end up writing a definitive text on an Ebola outbreak in West Africa?
Because Farmer actually went to West Africa during the devastating 2014 Ebola epidemic. He was on the ground treating patients. And what he observed there required the lens of an anthropologist to fully explain. In this book, he points out a chilling discrepancy. During that entire global panic, there were almost zero Ebola deaths in the United States or Western Europe. The catastrophic death toll was entirely concentrated in West Africa.
And the easy, lazy assumption would be to blame local governments or suggest the virus was somehow geographically stronger.
If we connect this to the bigger picture, Farmer's thesis in the book dismantles that lazy assumption. He argues that the Ebola virus was just the spark. The actual fuel for the massive death toll was the complete absence of basic public health infrastructure. No isolation wards, no gloves, no functional supply chains for 5E fluids.
And why was there no infrastructure?
This is where he diagnoses history. He traces that lack of infrastructure back through nearly 5 centuries of European colonial rule. He documents the rapacious extraction of West Africa's wealth, the rubber, the timber, the gold, the diamonds.
It is systematic.
Completely. The economic foundation of those nations was systematically drained for centuries by foreign powers, leaving absolutely no tax base or resources to build a hospital system. When the plague finally hit, there was nothing standing in its way. To Paul Farmer, pathogens are only half the equation. History kills people. Structural violence is a pathogen.
Structural violence is a pathogen. That is such a heavy, necessary reframing of how we look at disease. And it was this exact level of insight that propelled him into the most elite circles of global influence. We're tracking a life that started hauling water in a Florida bayou, and he becomes university professor at Harvard, which is the highest faculty honor the university can bestow. He is appointed the UN Deputy Special Envoy to Haiti under Bill Clinton. He wins a MacArthur Genius Grant. He is awarded the $1 Million Berggruen Prize.
His life was even immortalized in Tracy Kidder's 2003 best-selling book, Mountains Beyond Mountains. He transitioned from an outsider agitating the system to becoming a central pillar of the global health establishment.
But operating at the absolute peak of legacy institutions like Harvard comes with incredibly complex realities and institutional friction. Our sources detail a specific event near the end of his life that highlights just how fraught navigating these elite spaces can be.
Right. In February 2022, a situation unfolded at Harvard involving a prominent anthropology professor named John Komaroff, who was facing university investigations regarding sexual and professional conduct policies.
And the sources note that initially, Farmer was one of 38 Harvard faculty members who signed an open letter to the student newspaper, the Harvard Crimson. That initial letter raised concerns about the results of the university's investigations and publicly defended Professor Komaroff's character.
However, the situation evolved rapidly. Shortly after that faculty letter was published, a group of graduate students filed a formal lawsuit against the university. The lawsuit entered highly specific allegations regarding Komaroff's actions into the public record, alongside claims that Harvard had fundamentally failed in its institutional response.
And once those detailed allegations emerged via the lawsuit, Farmer, along with several other original faculty signatories, released public statements retracting their signatures from that initial letter of support. It is a stark example of the turbulent, complex institutional dynamics that define modern academia. It shows the tension between departmental loyalties, institutional procedures, and student advocacy.
Yeah, it illustrates he wasn't just a symbol. He was a human, navigating the highly pressurized environment of a major legacy institution during a time of intense cultural and procedural scrutiny.
Here's where it gets really interesting, though. When you look at the trajectory of his life, from the Bayou to the Harvard Faculty Club, the UN appointments, the global controversies, he never allowed himself to be fully consumed by the administrative stratosphere.
No, he fundamentally believed in the concept of accompaniment. He refused to manage global health solely from a desk in Cambridge.
Look at the profound symmetry of his final days. In February 2022, at the age of 62, a man who had won $1 million prizes and advised presidents passes away suddenly in his sleep from a heart attack. And he doesn't die in a sprawling Massachusetts state. He dies in Butaro, Rwanda.
Right there on the ground.
He was physically there teaching the next generation of doctors at the University of Global Health Equity. He spent his final hours doing exactly what he did in Haiti decades earlier, accompanying students and patients in a resource-poor setting.
It is a devastatingly early end to his life, but his architectural impact on global health is permanent. He is survived by his wife, Didi Bertrand Farmer, who is herself a formidable Haitian medical anthropologist doing vital work to empower young women and their 3 children. And the organization he co-founded, Partners in Health, has evolved into a massive global force. At the time of his passing, PIH employed roughly 7,000 people in Haiti alone, alongside deep-rooted operations in Rwanda, Lesotho, Malawi, Mexico, Peru, and the Navajo Nation.
And the momentum hasn't slowed down at all. The sources highlight an incredible update from just this year, 2026. The Paul E. Farmer Maternal Center of Excellence officially opened in Koidu, Sierra Leone. And what makes this facility so extraordinary is that it isn't just a basic rural clinic. It houses the nation's very first neonatal intensive care unit, a state-of-the-art NICU.
Which is the ultimate vindication of the preferential option for the poor. Building a world-class NICU in Sierra Leone is a direct continuation of his belief that the most marginalized mothers on Earth deserve the highest caliber of medical technology. Synthesizing all of this, the core takeaway from Farmer's life is that knowledge, whether medical, anthropological, or historical, is entirely useless if it remains abstract. It has to be applied to physically alter the living conditions of the vulnerable. He proved that equity is not a philosophical luxury. It is the fundamental prerequisite for public health.
He forced us to realize that the most dangerous diseases don't always show up under a microscope. So here's a final thought for you to take with you as we wrap up today's deep dive. The next time you are looking at health disparities, whether you're reading a news report about a medical crisis on the other side of the world, or you are simply noticing the difference in life expectancy rates between two different zip codes in your own city, I want you to ask yourself, what invisible history or what forgotten social structure is acting as the pathogen here? Because until we learn to diagnose the history, we are never going to truly cure the patient. Thank you so much for joining us for this deep dive. Keep questioning the structures around you, keep exploring, and we will catch you next time.